We use several devices. One of them is the internal bar that goes underneath the left lobe of the liver and hangs up the liver lobe, which allows to see the stomach better. But again, the key is to see angle of His. Without seeing this, you might end up leaving fundus of the stomach too large, and those patients, they typically gain weight or develop different problems like reflux or even leak easier. So this is what we do here in Cleveland Clinic.
Great. And also something that I picked up from my experience at the Cleveland Clinic, we have this great piece of equipment called the air seal, which actually improves our visibility with the camera better than what the regular trocars do. You know, you might have noticed that we have the problem of smudging of the camera lens. None of that stuff. You know, really, it's a great piece of equipment having the air seal to provide that good camera visibility.
Right, I agree. No, we experience with this. Basically, this is a trocar without physical valve. It's just an open tube with different degrees of air pressure, keeping the pneumoperitoneum intact without a physical valve. So the scope goes through this without touching any physical barriers. That keeps the visibility really, really good. And also, we've been experiencing with different new devices. Recently, I checked a device called Viking. It's a three-dimensional laparoscopic visualization, something similar to what Intuitive Surgical Robot offers, but for laparoscopy, which provides three-dimensional visualization and very high-definition imaging for better quality.
Dr. Moustarah, I know that your area of specific expertise relates to the BPD. Now, is there anything that you do from that perspective to improve your operative field visibility?
Yes, actually, thank you for posing the question. The obese patient, obesity in and of itself, when you start to talk about very high BMI, pose a challenge. And I think following through with a lot of the comments that Dr. Rogula had mentioned, I think these are all important. But if you were to approach this in general, I would start from having, first of all, a very good camera system and in your operating room. And I won't go into the details of that, and that sometimes is a limiting factor. But in terms of what we can do in the super obese, we have issues related to access, for example. Are we going to use a 10-millimeter camera versus a 5-millimeter camera to view our field? That makes a significant difference. Some people try to minimize the size of access and say they want to complete this operation with a 5-millimeter scope. It is possible, but visibility is compromised significantly. And then, aside from the positional changes in insufflating the abdomen to maximally, maybe sometimes even using two insufflators to lift the weight of this abdominal wall and to overcome the resistance posed by it can help. The other thing that I'd like to mention to any surgeon doing bariatrics is not to be hesitant to insert another 5-millimeter port if that helps with retraction and exposure to optimize views of different areas of operation.
Great. Those points are all well taken. Now, does anyone have experience with the Olympus EndoEye as against maybe a Stryker 45-degree scope, which a lot of us are familiar with?
We haven't used the EndoEye ourselves here. I remember from my time in the United States, in Cleveland, we had worked with it a little bit, and I think Dr. Rogula might be able to speak to that if they're still using it.
Yes, we tried the system, and some of our colorectal surgeons, they still use it. No, I think it's a very, very good device. It provides very universal, different angle view, which can be adjusted easily. The downside of this, in my opinion, the resolution is not that great, at least for the model that we tried, and I think it still requires some improvements. But certainly, it's a good option for difficult bariatric cases where you have to look from different angles on stomach or other organs. So definitely, it's a good approach. Now, another thing, in addition to Dr. Moustarah mentioned, we use scopes of different lengths, and sometimes a very long length of the scope helps getting closer to the area of interest. So if you're practicing bariatric surgery, make sure you have a different angle of lenses and different lengths available.
Okay, great. Dr. Merchant, do you have any pearls of wisdom to add to the discussion here?
When I was at my fellowship at Emory, one of the things that we used that was really nice was a pneumatic camera arm, and the reason we really liked that was because it took away any sort of factors from the assistant holding the camera in terms of tremor, and that was really nice. And then the other thing I would think about is if your operating room can equip you with the most high-definition laparoscopy equipment, I think the more detail you can see, the better off you'll be doing bariatric surgery. And I agree with everything that Dr. Rogula and Dr. Moustarah have said regarding being able to see the angle of His, retracting the liver, and reverse Trendelenburg. All in all, really what this comes down to is experience, and I think experience is the best, most important component of having a good visual field.
Vasanth, can you hear us?
We can
hi, Dr. Rajkumar from here. Can you? Hi.
Hello, Dr. Rajkumar.
Hi. See, two things. I would like, the first time I saw an endo eye was actually with Professor Palanivelu at one of his conferences. He has got one. So maybe he can tell us what it is like to have an endo eye. I'm going to ask him to talk about the endo eye since we're talking about it.
Absolutely.
Vasanth, I wish the discussion is going very well, and the clarity is fine, audio is very good. Here all, every delegate is enjoying it. I appreciate it. Yes, Vasanth, there's high definition, and this is endo eye, and we are using it regularly, and no doubt it is very good. More than that, endo eye, the single incision when we went in, that equipment is the Olympus works very well for us. That way, I think bariatricians are very little doing it. Either adapter we have to use Karl Storz with the side one, or Olympus endo eye is the best one because that is one no side, one projecting it. We found it very good. Okay, you continue your proceedings. Okay, yeah.
Thanks for your input, Dr. Palanivelu and Dr. Rajkumar. If the panelists have nothing to add, we can probably move on to the next question. Okay, yeah. Great. So the next question that we were asked is cholecystectomy part of obesity surgery? It's actually a very practical question. I mean, all of us have encountered this question in our own practices at some point in time. And really, the rationale behind it is all to do with cholelithiasis. You know, the cholelithiasis develops in about 38% of patients within 6 months of surgery. That's what we see from literature. And up to 41% of such patients become symptomatic. And obviously, the rapid weight loss that we see, especially in procedures like the sleeve or the bypass or the BPD, can contribute to the development of gallstones by increasing the lithogenicity of the bile. The high frequency of cholelithiasis can be reduced as low as 2% as long as you have a 6-month course of Actigol or also deoxycholic acid given prophylactically after weight loss surgery. The decision to perform a cholecystectomy at the time of a gastric bypass or a BPD or a sleeve for that matter is controversial. Some surgeons recommend performing cholecystectomy at the time of the initial bariatric surgical procedure itself, as long as the patient had symptomatic gallstones diagnosed preoperatively. The surgical opinion about asymptomatic gallstones is more divided, and studies have failed to demonstrate a benefit for simultaneous cholecystectomy for incidental gallstones at the time of a gastric bypass or a sleeve or a BPD. Also to be factored in is the risk of developing choledocholitis, which can be difficult to treat in a postoperative Roux-en-Y patient especially. If you do make a diagnosis of choledocho, status post Roux-en-Y using ultrasound or MRCP, it raises the issue of relative inaccessibility of the duodenum due to the altered anatomy of the Roux-en-Y configuration. As a result, ERCP can be very difficult to perform. This is a practical issue with choledocholitis after a gastric bypass. The choices that you have, you can either facilitate percutaneous access to the gas using a transhepatic percutaneous access, or you have a IR option. If you have some sort of radiologic markers that tell you where your excluded portion of the stomach is, if you have sewn it up to the anterior abdominal wall, your interventionalist or your interventional radiologist can access the gastric remnant, allowing you access to the CVD. Also, if you have a surgical gastrostomy at the time of initial procedure, again, you can have access to the gastrostomy and the CVD. Dr. Rogula, do you have any thoughts on cholecystectomy at the time of the initial surgery? We developed a pretty well-established way of dealing with this. Back in the years when I was in Pittsburgh, we published a study showing quite clearly that doing preventive cholecystectomy brings no major benefits, as you mentioned. So currently here in Cleveland Clinic, even with patients with actual stones at the time of bariatric surgery, we do not perform cholecystectomy. We only do this when stones becoming more symptomatic, and to prevent stones, as you mentioned, we give Uzobiol, and we also do pre-operative ultrasound to detect these problems early enough. And as you mentioned, we do transgastric ERCP for choledocholitis in gastric bypass patients, which is a challenging thing, and we do this with the laparoscopic approach. So this is what we do here in the clinic. Great. Dr. Moustarah, how about your experience with cholelithiasis and BPD?
I think the issue takes on the importance that you mentioned in the context of the BPD because of the fact that if a gallbladder is left in place and with the accelerated rate of gallstone formation, the big question is, what do you do when these gallstones become symptomatic and in the setting of choledocholitis? So I can tell you that our practice, our institutional practice here, dating back to the 80s, between the very late 80s up till about 2008, when they were doing mostly open BPD surgery, the gallbladder was removed routinely with these operations. Now with the laparoscopic era, we've become a little bit more selective for many reasons. Now, if we find that there is evidence of cholelithiasis on ultrasound, we basically prioritize the gallbladder for removal during the surgery, but that's not the only factor. We take into consideration the operative time because we don't want to unnecessarily increase the operative time just to add on top of an already very complex laparoscopic procedure, a cholecystectomy. Now, but we also take into consideration visibility in the area of dissection of the duodenum. If the gallbladder is large and is hindering visibility and access for division of the duodenum and for creation of the duodenal ileostomy, we certainly take the time and effort to remove it safely. Now, that being said, if we do, I also want to mention that there are patient populations that we should think about. For example, the very young and the female population that are of childbearing age. Those group of patients are prioritized for gallbladder removal at the time of laparoscopic surgery as well, if factors are favorable, meaning medical factors under anesthesia are not a contraindication, the patient's stable, time is reasonable. Why? Because of their lifetime risk of developing cholelithiasis and complicated cholelithiasis. Now, when we do leave the gallbladder in place, we are also familiar with the evidence that you mentioned, that ursodiol does play a role in reducing postoperative development of gallstones. The question here is compliance. We do prescribe it to patients for 6 months after surgery. How many actually take it for the full 6 months, we're not sure. But we do know that the incidence of gallstone disease is actually low. And there was a study done in the context of laparoscopic BPD where they found that if the gallbladder was left in place, symptoms developed in about 8.7, 8.8. I think it was 9% of the patients that do come up with problems, and it was felt that this number was low enough that they can practice selective cholecystectomy at the time of surgery and then deal with any symptomatic gallstone disease as it develops in the future, knowing that the weight loss would have led to optimization of visualization, improved the risk profile of a second operation anyway.
Thanks. Well, we'll move on to the next question. What I have here is...
Vasanth, can I just interrupt for a quick minute? This question was discussed at if you look at the IFSO proceedings in Delhi 2012, you see, after band or after a sleeve, the percentage of people that develop gallbladder stones is actually very low. But after BPD, the lithogenicity of the bile is much higher. The bypass, it's intermediate. And one of the conclusions in the IFSO was that for a BPD of any form to proceed with gallbladder removal, but for you to wait for sleeve and for band, especially in India, and sleeve is the commonest done. There's not sufficient data for us to go ahead and do gallbladders, without even stone formation.
Great. Thanks, Dr. Rajkumar, for your input. So the next question that we were asked is a good one. When you have an on-table identified perforation, esophageal perforation after a bougie insertion, what do you do? Dr. Palanivelu, do you want to take this one?
Obviously, I will say I never used bougie. I'm against you using bougie, so no perforation in my series. But if it is there, and mostly it happens, that means better to do suturing carefully. Then they can go on bypass, no problem, because it is esophageal stomach perforation can be repaired primarily, so there is not a problem. You can do it. And bougie, I think it is. I don't know. Most of the centers have given up. Is it not?
True. I think some of the surgeons here.
I think. I think this bougie now currently using it. It is a very flexible, and I think it will not perforate. No, my bougie which I mentioned for Achilles, I'm sorry, for bypass surgery is what we use bougie. It is so flexible. And I don't think one can injure unless it is folded and push. That traumatic way one should not use it. Usually under guidance we are passing it, we'll know it. I don't think it is. But if it is injured, suture and continue the procedure. And only thing post-operative care should be careful, and gastrographic study should be done before giving feeding to the patient.
Right. Dr. Kannan, Dr. Rajkumar, do you also feel the same way about this particular situation?
Yeah, I think esophagus you can repair primarily. I don't think there is no harm in it. We only use bougies during the performance of a sleeve gastrectomy to restrict the size of the sleeve. For bypass and all, we don't use bougies. But yes, if I did see a perforation, I would repair it on the spot, exactly as Dr. Palanivelu said.
Right. And Dr. Rajkumar, what size bougie are you using? Are you using a 36?
36.
36. Okay, great. Right. So I think that settles that issue. The next question we have is the issue of obesity and hernias that's been thrown to us from the audience. Dr. Merchant, do you want to take this one?
Sure. I think this is, unfortunately, a bit of a complicated question because we don't really have a right answer to this in this day and age. You know, when a patient comes to see us with morbid obesity and a ventral incisional hernia, the general practice is we tell our patients to go lose some weight. And ultimately what happens is they go try and lose weight, they come back about a year and a half later not having lost any weight. Sometimes they'll end up in the ER with an incarceration, and now you're dealing with somebody with a potentially higher risk than they were before when they saw you in the clinic. So that begs the question of what should we do the first time we see these patients. And I think there is some data in the literature indicating that there's a role for concomitant bariatric surgery or bariatric surgery with interval repair, laparoscopic, of a ventral hernia. The data really is not level 1 data. It's not randomized. It's not a clinical trial. And so really this is a sort of a hanging question that doesn't really have an answer in my book. My current practice would be to, if the patient would qualify, to put them through a bariatric program initially and perform bariatric surgery and then possibly a delayed laparoscopic repair. But I think this is an interesting question, and I'd be interested to see what other people think about it.
Well, you talked about predominantly ventral hernias. I think the recurrence rate in some series has been as high as 20% in a morbidly obese population if you go ahead and repair the ventral hernia without taking care of the morbid obesity component because of the raised intra-abdominal pressure. So that is certainly something to consider. And what about the issue of hiatal hernias? What do you do when you see a hiatal hernia when you're going in to do a lap band or a sleeve for that matter?
My practice is I do a preoperative EGD on all of my bariatric patients. That sometimes helps me identify a hiatal hernia before surgery. And if I do identify one, I usually will recommend, my practice is to do a sleeve gastrectomy with repair of the hiatus and reduction of the paraesophageal or the hiatal hernia if it's fairly large. If it's small, I think you can proceed with a band or a bypass. But I think that, and again, there's no data, there's no really good data to really steer a person one way or the other here. There's definitely a number of case reports and case series in the literature about doing a paraesophageal hernia repair in a morbidly obese patient with a concomitant sleeve gastrectomy. But there are also a few reports out there where they've done gastric bypass, and really both cohorts of patients have done quite well. So again, there's no real good answer to this. It's really surgeon and experience dependent right now.
Okay, and when you say that you do a hiatal hernia repair, do you just throw a couple of sutures anteriorly at the level of the crura, or do you do a formal posterior cruroplasty?
I would do a formal posterior cruroplasty. I would do an anterior cruroplasty if needed, but most of the time, just as for a standard paraesophageal or a large hiatal hernia repair, I do a posterior cruroplasty, and if it's a very large defect, the possibility of using mesh. Okay.
Dr. Rogula, what is your thought on this issue?
Yeah, we had a couple of patients, I think at least 15 or 20 with these problems recently, which we fixed the hernia at the time of bariatric surgery. So in my opinion, you don't really lose that much by fixing the hernia at the same time. You obviously add some time to the operating room, but you're not risking that much putting that mesh in place and maybe stitch the hernia primarily with a couple of stitches. From those several patients, they all surprisingly did quite well. Now, keep in mind that weight loss after bariatrics, especially gastric bypass, is pretty rapid. So usually within a month or 2 months they lose like 30 or sometimes even 50 pounds, which is good enough to keep the hernia intact. On the other side, if you don't fix the hernia and if you do gastric bypass, the risk of incarceration intestine is pretty significant, because those patients, they have no big stomach in between esophagus and the jejunum. So if they incarcerate any segment of the small intestine, there is very significant risk of backing up pressure and aspiration. We actually had a patient like this who unfortunately had serious complications with very severe aspiration. So you have to keep it in mind. Sometimes putting a temporary mesh, biological mesh, if you really cannot fix the hernia well, it's better than just leave the hernia open. Sometimes if we see a large piece of omentum in the hernia, we rather leave it alone inside the hernia and use it as a temporary plug to prevent from this really bad incarceration of the intestine into the hernia. So my honest opinion, you have nothing to lose by fixing the hernia at the same time. If they fail, that's fine, just come back and fix it. But from those patients, they almost all of them, they did well, and they had no recurrences.
Okay, great. And Dr. Rajkumar, what do you do from your perspective when you see maybe a hiatal hernia and you plan to do a band?
Vasanth, it's a good question, because a lot of Indians have got reflux problems. And when we do a sleeve or a band in such people, the post-operative reflux is terrible. So as a policy, if a patient has a large hiatus hernia, I do a 24-hour pH, evaluate the reflux, and then I always do a bypass in such patients. And I also add posterior crural sutures to ensure, I'm adding belt to braces. And we never do a sleeve. Indeed, I've had to do a couple of people done elsewhere. One of my own sleeves, we had to convert them into bypasses only because of the reflux. I'd like to also ask Dr. Palanivelu whether he agrees with me.
Vasanth, I think in these situations, and when hiatus hernia is there, if you do like a correction of the hiatus hernia, then proceeding with the bypass is the first choice. But recent studies and our own experience we have seen, and particularly for young people when they come, where no band we do it, of course we discourage in our department. We go for a sleeve gastrectomy, though it is known that sleeve gastrectomy induces reflux more, but not correcting without hiatus. Correcting hiatus one can do sleeve without corrections, and if it is wide hiatus, something is going from, then bypass may be choice. Either can be done depending on the individual's choice.
Okay, great. Like Dr. Palanivelu,
at this juncture, I will put upon, and hernia, when you just left the incisional ventral hernia in a correction, at this juncture, I like to say a word. You recently, 2 years back, we published an article as well, combined ventral hernia and bariatric surgery. And it is the stomach and the jejunum, as long as properly done, and it can be done with the experience. We published the article as well in Obesity Journal. And here because some of the cases they did, we don't want to put a mesh, we corrected these, and subsequently during the post-operative, the patient developed intestinal obstruction, then I have to correct it. That particular case, because we could not approximate suturing, wide defect, I have to place a mesh. And those people went on very well, no infection. Subsequently, slowly we moved on, and now ventral hernia we repair along with that. We published article. It was widely referred. Everybody accepted that yes, sleeve surgery can be done. Now I think can go ahead with that.
Great. And Dr. Rajkumar, when you said that you would do a 24-hour pH study before you decide on what you're going to do you look for a significant reflex as in a Demeester score of maybe greater than 23, or does your management vary if you see a score of maybe, let's say, 16?
Exactly. If I find that the Demeester score is not very high, in those cases, as Dr. Palanivelu was saying, we could still look at a sleeve and only crural repair. But if the patient had very severe reflux, and I know that a cruroplasty alone is not going to be enough. If you do a sleeve, the intragastric pressure is going to be high. It's going to push whatever little acid is there upwards. In those patients, I would prefer to do a bypass. The one last point I would like to add about, as sir was saying about mesh, I think the worry about mesh and infection is probably a little overstated, don't you think, Vasanth? More and more papers are coming out. Colostomies are being closed with a mesh. Colostomy closure and then a mesh. To prevent a paracolostomy hernia, preventive mesh. And all those are being accepted. And those are being accepted, we should start thinking of putting a mesh even in clean or clean contaminated surgeries.
Absolutely, your point is well taken. So moving on to the next question. Well, this is again something to do with intraoperative problems. Stapler failure during anastomosis. What do you do? Dr. Kannan, do you want to take this one?
I think you mean on-table failure.
On-table failure. You picked it up. There is a staple line dehiscence.
Yeah, I think Raj will be better than me. Even recently we had this problem, and I think the answer is anybody who has seen and followed Dr. Palanivelu and learned the suture, we simply have to go on and complete the anastomosis hands-on. Indeed, Vasanth, I tend to do personally all my gastrojejunal anastomosis hands-on. Wherever the jejunal-jejunostomy, if the position is not proper, I tend to do the jejunal-jejunostomy also hands-on. And I think it's a good carry-home message that in any situation, if a stapler fails, one should be ready to do it as a hands-on.
Great. I think pretty much all of us would agree that that truly is the way out. I don't think there is any two things about it. We have another interesting question.
Vasanth, can I intervene on?
Oh yes, Dr. Palanivelu, please.
Yeah. Staple failure is two types. One is circular stapler failure is technically is a difficult way to manage, and in that case we have to disconnect and we have to trim that segment of the jejunum by say linear cutter. Then we have to go ahead with the suturing. But in case if it is a linear cutter, we are going to use a side to side, as we do a gastric bypass in our group. And that cases very well we can continue the same suturing without any sacrificing the bone. I think it is technical wise. It is just fair to that. That's all.
Perfect. And do you have any preference as to a circular stapler with its known incidence of anastomotic stricture and the anastomotic index? Do all these factors come into play as opposed to a linear stapler, which is thought to be less of associated with less of a stricture?
Yeah. Vasanth, here in we used to do a gastrectomy cancer regularly. We found circular stapler stricture is little higher incidence, and also reported leak rate is more. Then that made us to go for a side-to-side anastomosis with a linear cutter. And same thing adapted for gastric bypass, and 2 centimeters jaw introducing the stomach and jejunum. It is side-to-side tension-free, and anteriorly that the entry of the staple be sutured. And that way, still now there is no single leak we could have. I personally feel this, if you want to prevent a leak and linear stapling, vertical, side to side, and a tension free, that is the best my experience.
Perfect. That's the technique that I tend to use too in my practice.
Vasanth, can I just say quickly that increasingly the data is showing that all over the world, I agree with everything that sir said, but all over the world there is a general tendency to go towards, especially in the US, to the Orwell, and I don't think that's industry driven. I will tell you why. However much I do hands-on, I try to measure and do exactly 2 centimeters. It's still rough. You put a linear stapler and you plan to the ethicon level exactly how much. That's also kind of approximate. But when you use a circular stapler, we know that it has a diameter, a circumference of exactly 25, and the highest diameter of exactly 8. So 3 of us are doing, or will all 3 of us are going to have the same diameter, and studies and comparison becomes much better. So because of that standardization, it's getting a little more. Also, it is a slightly higher incidence of stricture, but a slightly lesser incidence of leak after the initial learning curve with the Orwell. I mean, I went through that learning curve, but then I'm back to hands-on. I'd like to also ask Dr. Kannan his opinion on the circular staple. Yeah, I feel circular staple is much safer. I feel.
Okay, true, and it also has the advantage of cutting down on the overtime in most surgeons' hands. So that's the point that's well taken. I think we can probably move on to the next question, which is management of the super morbidly obese patient. In what way is it different from regular obesity surgery? Dr. Moustarah, do you want to take this one?
Sure. The super morbidly obese patient, as you're aware, is a different kettle of fish, if I can use the metaphor, in a sense that the risk profile is augmented, and study after study have shown this. So not only do we want to look for the operation that provides the patient with the best outcome in terms of weight loss, sustained weight loss, and resolution of comorbidities, but we also want to keep in mind that any operation comes with a higher risk profile for this patient. So in my personal opinion and practice, what we offer these patients is the biliopancreatic diversion with the duodenal switch operation. But what we've come to appreciate over time in the context of laparoscopy, that we have to be reasonable about the application of this technology and to consider staging the procedure. And people that embarked on this very early in the days of laparoscopic BPD, such as Dr. Gagne, discovered this, and they've reported on this with on a group of patients that they found higher morbidity and mortality, unfortunately, at the time. And they recommended the sleeve as a staging procedure, and that's how it took off as a primary procedure over time, as more people tried to use the sleeve. So there is a role of using the sleeve as a primary procedure for the super morbidly obese. And in fact, I had a patient with a BMI of 84 that came wanting an open BPD, and I kind of gave him the risks and benefits and the options, because our institution is known to have offered open BPD surgery. And we agreed that a wiser choice perhaps for him is to stage this to laparoscopically, keep the access minimal, avoid all the problems associated with ventral hernias and wound complications that develop in such supramorbidly obese patients. And we proceeded with a sleeve as a primary operation, and then the duodenal switch to follow, usually in about a year and a half's time.
Okay, great. Dr. Rogula, what are your thoughts?
Yeah, no, I agree with Dr. Moustarah that in most of those extreme situations, duodenal switch is probably the best solution. But I personally think we should give a chance to those patients and start with something less dramatic and do probably a staging approach. So I can tell you a few examples from our experience. So we had patients with BMI of 80 or more, and we did a sleeve, and they did quite well, and they lose weight. Obviously, they end up being obese, but they were quite happy, and the comorbidities were resolved. Now, some of them, that one stage is not enough, and then we add another stage, and they did fine. The extreme example is a patient, 25 years old, who came with the initial weight of 1,150 pounds at the beginning, a huge man. We did a sleeve first, then we converted to bypass, and then we elongated the bypass to make it more malabsorptive. And he did quite well at the end. So I think staging approach is good. You cannot really predict how those patients will do, but giving them chance with less invasive approach is quite reasonable. And also, our approach to those extreme situations, like BMI of 100 or more, is that we typically admit those patients for a week or sometimes 2 weeks for very extensive medical, very restricted approach and diet, and sometimes dialysis with giving them Lasix in great amounts to optimize them for the surgery. And obviously, the operation is challenging. You have to be prepared, have an appropriate equipment, long instruments, an appropriate table and team, And postoperatively, those patients, they have typically a severe sleep apnea and all kind of problems. So in essence, those patients, they need to be operated and treated in very highly specialized places with large volume and appropriate equipment and personnel.
Okay, Dr. Palanivelu, if I might ask you to weigh in on your experience with the super morbidly obese patient.
Vasanth?
Yes.
So this case staging is which we prefer. We do a sleeve gastrectomy. Then subsequently, we depending on the patients, many of them they are primarily lose weight and they become very happy. If we have to do a second stage, that we go for duodenojejunal gastric bypass, short PPD, what we call that way. We make it like a gastric bypass. We take the jejunum and we from duodenum part 1 we make it the bypass second component as a second stage. That way we prefer our approach.
Okay.
Yeah, I think you would have seen our publication on duodenojejunal bypass.
Yes, I have, and that's why I directed the question to you.
Yes. Okay.
Dr. Rajkumar, how do you manage these super morbidly obese patients?
Like sir said, first stage sleeve, but interestingly, in some of them, the sleeve, for the last 2, 3, 4 years, they seem to be happy enough with the sleeve alone, and increasingly, with a large number of publications, that the sleeve alone can be not just an initial, but as a primary treatment itself for morbid obesity. Certainly, my preferred things to do the sleeve is the first stage and follow it up. I don't do a duodenojejunal like sir does. We then later convert the sleeve into a definite bypass. Standard Roux-en-Y gastric bypass. That is at this point of time my preferred technique.
Yeah, I work in a government institution where nowadays we have started doing bariatric work. Right now we are happy with the sleeve gastrectomy. They lose quite a lot of weight. We are observing.
Great, perfect. I think we can move on to the next question. Is there a optimal anastomotic technique in a gastric bypass? Dr. Rajkumar, you want to start out?
Optimal anastomosing technique.
Yeah.
For the GJ or for the GJ?
For the GJ, yes.
Yeah. There are 3 ways of doing it. Of course, the hands-on, the linear stapler, and the circular stapler. And over the last 12 years, I've jumped from one to the other, and I've finally settled for hands-on, 2-layered anastomosis using proline for the outer layer and PDS for the inner layer, or an endostitch with the polyester, with jumping from jaw to jaw for the inner layer. I measure out the exact size of the anastomosis. The anastomosis is 2 centimeter anastomosis, and I try to do it about 1 centimeter from the staple line of the gastric pouch. This is mostly anterior. Sometimes it's posterior. So this is at this point of time, this is my preferred technique of anastomosis. I don't splint it, etc. And I always do a leak test immediately after that.
Okay, and you mentioned that you in some cases you potentially use a polyester suture for the inner layer. Do you use polyester or polysorb?
Because it's a good question. Whenever I get polysorb, I use polysorb, which is really like Michael for the Karika is sitting here. When I get polysorb, I use that, but very often here the polysorb is not available. Only the polydac is available, which is really polyester. It's something to do with the availability of inconvenient.
Gotcha.
Good question.
Okay. Great. I think Dr. Palanivelu, Dr. Kannan, do you have anything to add to this?
Kannan.
You always do your surgery in laparoscopy, or you do mini laparotomy and do procedures? I saw a surgeon in the United States who made a 2 or 3 inches incision and did all these bypass procedures.
No, I tend to do mine laparoscopically in at least 99% of the time. It's a rare occasion where we have to convert to open, especially with prior surgery, dense adhesions. That's typically the only time in the interest of getting the patient off the OR table that we convert to open, but typically 99% of the time it's laparoscopic, true laparoscopic.
I'd like Dr. Palanivelu to also talk about the his favorite anastomosis and why he has now settled on that.
I think what Kannan is saying, I think there are some surgeons, for gastrectomy they do mini incision and they put a retract technique like, but it is beginner's learning curve, it's fine. But once learn laparoscopic, total laparoscopy is the best way to go. And of course, we never convert just like any procedure. Here we initially we started with a transverse gastric pouch, then slowly change on now vertical based gastric pouch. A short gastric pouch is most preferred now, and of course circular stapler we use a small percentage, and the larger number we use a linear cutter. And the end suturing, if you use it, we use always prefer single layer, extra mucosal type, and we use the PDS 20 or Vicryl. Vicryls initially easy to handle, but once learn, we found PDS is better, and this is what our standard preference now. But the technique more changes is still the controversy is the length of the PPD, pancreatic limb, and the alimentary limb, and BMI and these correlates, but still it is unsolved. It is going on, and it is how much the minimum one needs for the from diaphragmatic flexure for short segment, and that is only. But technique as far as concerned, it is more or less settled. We are standard last 10 years now.
Great, thank you. The next question we have from the audience is, what is the role of robotic bariatric surgery? Dr. Rogula, do you want to take this one?
Thank you. No, we've been doing the robotic bariatric surgery since last year. I did about 50 cases, and I'm pretty pleased with the results. The advantage of this is it provides extreme stable platform to see everything, and also precision of hand-sewn anastomosis is really good. I have a short video. I'm not sure if you can show this. If you could pass presentation to me, I can show it really briefly. If you can pass my presentation to me, Vasanth, I can show it.
Dr. Kannan, can we give Dr. Rogula the presentation rights?
Yeah. It would be nice if we could see his robotic thing, Kannan.
Yeah, so now I can show you how I do this. So essentially, the advantage is a great visualization, and the second advantage is that you can do a true hand-sewn anastomosis with great precision, with minimal risk of leak. We had no leak so far. Can you see it now?
Yes, we are able to see it.
Right. So you can see it's a very steady platform. Nothing is really shaking, and those instruments, they have a full reticulation movement, so you can really sew it as with your own hand in open surgery. And this particular video shows hand-sewn closure of jejunal anastomosis and thoracotomies. I do this manually like this. So you can whisk those instruments back and forward in different directions. Now, I found great advantages for very complicated cases with a large BMI. With the robot, you cannot really feel if the patient's body mass index is 25 or 85. Those arms, robotic arms, are very strong, and you can do this very easily. Still, we don't have robotic staplers. They're coming out sometimes this year, so we use this laparoscopically. And now you can hand-sewn gastrojejunal anastomosis, which can be done in great precision. And coming back to previous questions, in my opinion, hand-sewn is probably optimal choice for the anastomosis. I think leaving any type of foreign body, even a small stapler or non-absorbable stitch in gastrojejunal anastomosis usually causes some problems. So that's why I prefer doing this robotically with the precisions as you can see now. So overall it's good, it's expensive. Not everybody has robots. We are quite fortunate here to having several robots, and we've been using this pretty heavily on bariatric surgery. Anybody else have some experience with robots?
Yes, those were all good points, and that was a great video. Thank you, Dr. Rogula, for showing us your technique. But really, this I think is the question I would put forward to the panelists. In this era, in the healthcare era that we are in, where insurance reimbursement is coming down every day with Obamacare and with outcomes and with cost of surgery on top of everyone's mind, if you cannot justify a superior outcome using new technology, in this day and age, is there still a role for robotics? As far as I'm aware, there is no large-scale study that demonstrates a clear benefit of robotic bariatric surgery over conventional laparoscopic surgery. We do have parity, meaning there is non-inferiority with the robot, but do economics play a role? I would also like to hear about this issue from the Indian context, where most of the people tend to be self-pay patients as opposed to the United States, where most of the patients are covered by insurance.
If I can comment on this before somebody else comes up. No, there's really no major data showing benefit. There's quite recently published a large series of close to 2,000 cases where they showed much less leak, but still, we're comparing about 1% of leak with laparoscopy to about 0.02% with the robotics. So there's less leak, but still, even laparoscopically, you can do this very well with very small amount of leak. So I think a robot will probably find its own niche, its own place in bariatric surgery. In my opinion, possibly this would be difficult residual cases of very high BMI, especially central abdominal male type of obesity with difficult laparoscopic access.
Okay, great. Dr. Palanivelu or Dr. Rajkumar, do you have any thoughts on the robot and bariatric surgery?
Robo, yes, it is talking. I don't use it. I don't have first of but I have used the Robo in Italy. I've seen the utility, but right now Robo has not shown any extra benefit by doing it in GI surgery, and particularly so as well as bariatric. So I don't know. People have to comment. As you already mentioned, there is no large studies to say which is better or not. But it is an extension of laparoscopic surgery only. So it is a robotic assisted lap surgery. If one can duplicate laparoscopic surgery well, this additional port, it is Rajkumar was commenting, people who have got a tremor in hands, they can use it. Probably that maybe that kind of people can afford, and they can use it very nice advertisement strategy. Not we have a robo, we have a robo. As usual, Americans always makes it a point, and urology, and now it has become a compulsory. FDA once approved. Robo is making advertisement. I see in the boards lot of places. Now newspaper in India started advertising. In future, only surgeons now with the skill who can perform equal laparoscopic surgery. The problem is going to be carpets can advertise the problem. Right now, I think in India, patients not going to benefit. That's all I can say.
Dr. Vasanth, we do have Dr. Oscar Gonzalez from the Valde University, who has a large experience with robotic sleeves as well as bypass. So I will request Dr. Oscar to offer his comments on robotics.
Hello, good afternoon. About robotics in bariatric surgery, I have to say that that's true that performing anastomosis by the robot is very, very easy. But in the bad thing, we think that economics are very, very high. And we are afraid that these economics at the end rely in not the use of an helper, which is not needed to perform robotic surgery. I'm not sure, and we have not found any improvement between laparoscopic surgery and robotic surgery yet, even economic. You know, it's clear what I mean?
Can you say the last sentence? What is that laparoscopy?
It's not improving the results in between robotics and laparoscopy.
Yeah, that is what you know.
It's good. I forgot. It's good for the surgeon because the surgeon is suited and it's more comfortable to operate it on with the robot. That's true.
Yeah.
Vasanth, the only robot that I like very much is Rajinikanth, who's a robo.
No, the superstar is ever popular. You know, there is no comparison to that.
Yeah. Vasanth, on behalf of all of us, I have to know, robotic surgery word is not correct to use it. No, it is not a kind of robo operating it. There are two kinds of robotics. It is a computerized chips and instruments we operate. So why not you call robotic assisted lab surgery? And this is a robotic company makes an advertisement. Let them advertise. Why surgeons advertising like this? Unless the robo comes, operates. Now that stage you can't robotic, no?
Right. Thankfully, we are not at that stage yet, or we'll be out of job. True. Great. I think we are kind of running short of time here. Maybe we have time for a couple of other questions that we can discuss. Another question that's been asked is about the issue of obesity.
Vasanth, you can initiate the discussion about herniation after surgery, defects, mesenteric defect, and that kind of spaces. What is the other faculty's opinion? Now, some surgeons, that kind of initiation may be useful for the surgeons and participating in the conference.
Great. Dr. Palanivelu, why don't you take it right from there? What is your policy? Do you routinely close the jejunostomy defect and the Peterson's defect? Do you routinely close, or do you just leave it open? What is your thought?
Yeah, the mesenteric defect, all cases we close, and but Peterson's Brown, that defect we don't close. But after which, so much we have done. But we had one hernia. I have to do laparoscope correcting it after 1.5 years. But in the Western countries, I know that report is little more. Morbid obese people, when they lose weight, the tendency for hernia is likely more. But Indian people still be very gross, super obese, very small percentage. Majority of them get it just morbid. When they lose weight, the herniation in the Peterson defect is not that much. So we don't close routinely.
And what is your technique? Is it an anti-colic anastomosis, or is it a retrocolic?
We split the great momentum and we take the alimentary limb anti-colic.
Okay. And have you seen a difference in the hernia rate, internal hernias, between the two techniques, the retrocolic versus the anti-colic?
Yeah, I don't use at all mesocolon. So my experience of herniation not there, because when we started gastrojejunostomy or even obstructive duodenal ulcer in our department, when we got training post graduation at Madras Medical College, even there we used to anti-colic gastrojejunostomy. So when I applied laparoscopy for ulcer, I started anti-colic, bariatric surgery anti-colic, and gastrectomy also anti-colic. So I'm not come across any. I did not have any chances for the mesocolic hernia, so anti-colic. But anti-colic and the mesocolon reported evidence says higher incidence through mesocolon. No, that way I think it is. But mesenteric defect has to be closed. That is my opinion. And Rajkumar, Kannan, they have to stay there. And your opinion also maybe.
Vasanth, a lot of people are youngsters here. I just want to say that when you do the jejunostomy, that is a mesenteric defect. Between the mesentery and the mesocolon, that potential space is known as Peterson's defect. Number one. Number two, when you take a retrocolic loop for the GJ, the chances of Peterson's hernia are much more. Most of us here, certainly sir and I, we all take the anticolic. So I do a long anticolic Roux-en-Y with an omental split. We need not close the Peterson's defect, but in every case I close the mesenteric defect. Maybe we'll ask Dr. Kannan. He also agrees with the same.
Dr. Moustarah, how about yourself?
I agree with the last comments. In fact, most of the problems that were related to internal herniations were related to the mesocolic defect itself, and not necessarily the true Peterson's defect, which was appropriately described. Now, with the move in the past from making it retrocolic to anticolic, they avoided making the mesocolic defect altogether. So the Peterson's defect was still made, often closed, but not by all surgeons, and they still found a significant decrease in internal herniation rates with this simple move from retro to anticolic positioning. Myself, I always close the mesenteric defect at the foot anastomosis, the enteroenterotomy, and the Peterson's defect is often very difficult to close, the anticolic Peterson's defect, because I swing the alimentary limb to the right side over Morrison's pouch area and then make the duodeno-ileostomy. And I find it very difficult to close the Peterson's defect regularly, but I do make an effort at that.
Okay, great. And I agree with what the panelists have said. Pretty much, I think across the board, most of us have said the same thing, that the defect needs to be closed. It doesn't take too much time, and the risk of having an internal herniation and subsequent bowel necrosis is just not worth it. The one other question that's been put forward is the role of obesity surgery for adolescents, and what the best practice can be with regards to this issue. From my practice viewpoint, what I've seen is we pretty much, a screening criteria, what kind of a patient are you going to choose if you are choosing to do bariatric surgery in the pediatric population? That's very important. And the screening criteria that I've used in my practice is pretty much a BMI of greater than or equal to 35 with some sort of a significant comorbidity, meaning moderate to severe obstructive sleep apnea with the AHI of greater than 15, maybe type 2 diabetes, pseudotumor cerebri, severe or progressive steatohepatitis, something like that. That's usually the cutoff that I've used. Also, in these populations, it's important to make sure that you have some measure of physical maturity, as in you need the patients to be at least at Kannan stage 4 with a 95% predicted bone age. And that requirement is based on some theoretical concerns that a rapid weight loss after maybe a gastric bypass might inhibit statural growth if the adolescent has not reached adult height. Most importantly, it's got to be a multidisciplinary approach. The first line of defense is always going to be mostly lifestyle changes and dietary modifications. You need to involve a child psychologist in the process. Make sure that they really understand what they're getting themselves into. And then comes the choice of procedure. What procedure is the best? I think for the most part, I would stay away from the BPD in the adolescent age group, because the risk of nutritional deficiencies and the micronutrient deficiencies are probably not worth it, and then you have to ensure compliance in this age group, which makes it not worthwhile in my book. People do use the band in the adolescent population. The downside with the band tends to be the fact that it's a foreign body. It's got a slightly higher risk of re-op as compared to the Roux-en-Y gastric bypass, which incidentally is the most commonly done procedure in the United States in the adolescent age group. Also, the FDA, there is no FDA approval for using a band in person less than 18. Sure, we know it, and there are a lot of studies, a lot of practically acquired experience, but it's really not FDA approved in less than 18. There was a recent study that was going on to try and assess the efficacy of a band in less than 18. Also, the sleeve is a great procedure to offer in adolescent age group because the incidence of micronutrient deficiencies are lesser with a sleeve compared to a bypass. And God forbid the patient puts on weight and relapses as an adult, you always have the option of potentially converting the sleeve to either a BPD or a gastric bypass in future. That option is always open. So you're not burning any bridges. So to me, that's how I would look at this issue. How about you, Dr. Rogula? What is your experience at the Cleveland Clinic with the adolescent population?
Well, no, this is remaining very controversial issues still. Now I agree with you that multidisciplinary approach, reaching out to families, finding out why those kids are obese. Usually this is a social or family problem. This is #1 approach. Now, surgically, now our view is like yours. We should not do anything that might harm those kids. I don't think aggressive operations like duodenal switch or even bypass is appropriate approach to most of these kids. So we typically do less invasive things like sleeve gastrectomy or even gastric palpation, which seems to be working fine. But again, I would stress the importance of appropriate multidisciplinary approach. We have our own obesity pediatricians, doctors who are specialized in teens obesity, and they take care of those patients pre-operatively and post-operatively, in addition to our own bariatric team. So if you're planning to do obesity surgery for adolescents, make sure you have appropriate, well-trained pediatricians who know exactly what to do with those patients. I think it's really important. And don't do aggressive things.
Great. Dr. Rajkumar, how about your experience in Chennai? Is there a market for obesity surgery in the adolescent age group? And Dr. Palanivelu, I don't know what kind of patient load you see in Coimbatore.
Our New York Coimbatore. Anyway, Vasanth, there is definitely we are seeing that the adolescent obesity is on the rise here too, but all of us are cautious about unnecessarily taking on these patients, and like you said, diet, lifestyle, all these. In 2 or 3 patients, we tried in the 16, 17-year-old, we tried the intragastric balloons, but we're not very happy with those, and we then took off the balloons. And there's a general reticence about referral to a bariatric program in the teens. So right now we're treading very cautiously until the data is very clear. I'd like to hear Dr. Palanivelu as well.
I think, Vasanth, you gave a nice brief of your procedure. Same thing what we adolescents not that high percentage, but it is increasing now, and we prefer particularly by 14, 15, 16 years we prefer banding, and that it is a temporary procedure anyway. They lose weight and we take it out, and very rarely go for sleeve. But there are people now, the indication for metabolic problems like type 2 diabetes in adolescents, uncontrolled, and fatty liver, non-alcoholic and fatty liver is another problem is going up. These are the now indication not controlled by medical therapy, and we go for bariatric surgery in this group of patients. There just go for sleeve, and we find the results are good. And either band first choice, and if it is a comorbidity is more, for morbidity sake we have to go, then we go for sleeve gastrectomy. These are the choices of our patients.
Great. Unfortunately, I think we've run out of time, but it's been great interacting with this eminent panel. Dr. Palanivelu actually was my aunt's surgeon a year ago, and Dr. Rajkumar was my earliest mentor when I was getting into surgical residency. And obviously, Dr. Kannan is a pretty familiar face on the surgical scene too. I would also like to thank Dr. Rogula from the Cleveland Clinic, who's graciously lent us his time in the middle of his busy schedule, Dr. Merchant from Central Michigan University, and Dr. Moustarah from Canada, who's also been very helpful with his expertise, particularly with regards to the DPD. It's been a very informative session. I hope people over there have taken some good points away from this discussion over the past hour.
Vasanth, you conducted very nicely, and all the foreign faculties did a wonderful job, and each of them brought out their own experience. And on behalf of the moderators, Kannan, Rajkumar, myself, and all the faculty here, delegates, all of them are sitting quietly, listening, and enjoying. A lot of information they gathered, and I congratulate all the panelists. Made it a wonderful session today. And I hand over to Kannan to.
I think they started at 4 a.m. So, yes, they are talking. From 4 a.m. they are talking to us.
Vasanth, on a very personal note, so nice to see. This is from my heart. To see youngsters do so well and indeed surpass us in many fields. Will always give us a lot of happiness. Keep rocking, and good luck and God bless. Very happy.
Vasanth, this is Kannan. I like to take this opportunity to thank you for doing such a good job behind and the hard work you put in. And on behalf of ESOINDIA organizers, me and Professor Chandra Mohan, we like to thank every faculty from your side as well as our side. And I would like to appreciate my. I would like to place my appreciation on the audience for being patient, and it's been a wonderful show. Thank you one and all for making this program a success.
Great.
Thank you, Vasanth.
Okay, bye-bye.
Thank you. Bye-bye.
Thank you all. It's a pleasure.
Thank Professor Palanivelu, Professor Kannan, Professor Rajkumar. It was a wonderful session that we just had. We now go to the final session of this evening, and I invite Dr. R.P. Shanmugam